Okay, welcome back to the Regenerative Health Podcast. Today I'm sitting down and speaking with Professor Sunil Wimalawansa. Now, he is a professor of medicine, of endocrinology, and human nutrition. He has had an extensive career treating patients in clinical medicine, and he is a world expert in the vitamin D system and the effects of vitamin D deficiency on health. So, Professor, welcome to the podcast.
Hello, Max. Thanks for getting me involved in this discussion. I'm looking forward to have a fruitful discussion for benefiting the public.
Great. Well, tell us a little bit about your career and your obviously academic interest mixed with clinical work to kind of get you to this place of being an authority on vitamin D.
Yeah, I originally from Sri Lanka. It's a small island in Indian Ocean. Then I moved to United Kingdom for my postgraduate studies and my PhD and all this basic stuff. And but 10 years later, I moved to US. Now I'm in the US for 30 plus years and engage in both research and clinical medicine, academic clinical medicine, all these years, 40 plus years. I never done private practice. So throughout my career, I've been in academia and I'd like to continue that. But one more important thing, actually, but 30 years ago, I switched my interest from acute medicine to disease prevention using holistic approaches to the patient as a whole, and rather than looking at a compartmentalized medicine that we have been taught over the years in the Western medicine. Thank you.
And how did you get interested in the vitamin D system?
Originally, I have had a lab in back in Hammersmith Hospital, Royal Postgraduate Medical School back in 1980s. So we used to do some of the biochemical studies and mostly cell culture studies using active moiety of vitamin D, which is calcitriol. And that time we were interested about mostly about the cancer cell line to control their growth and reversing them back towards normal cell. They are very impressively, we could do that, but using higher doses of calcitriol. But that amount of doses, so the concentration will not achieve, is possible in human being. So we were worried what's going on. And now we know that it's really the circulatory concentration is irrelevant of calcitriol. What matters is the intracellular generation of calcitriol from vitamin D3 as well as 25-hydroxy D, because of these peripheral target cells like immune cells, cardiovascular cells, the brain cells, all has both enzymes to convert D3 and 25-hydroxy D, so calcitriol, into calcifediol into calcitriol active moiety. So these cells basically depending on the circulatory or blood concentration of D3 and calcifediol. So that's the reason we are measuring the 25-hydroxy D as a vitamin D status.
Yeah, it's a great opportunity to talk about the metabolism and the physiology of vitamin D. And as you mentioned, and a lot of my listeners who followed my work up till now know that the vitamin D that is generated in the skin and that we take orally actually has to go through a stepwise process of enzymatic transformation and activation before it gets to the active form, which is, as you mentioned, is calcitriol. So to talk to us through this process, how do you see the most important ways that the body is actually generating or intaking vitamin D?
The vitamin D historically, we're supposed to get at least 80-90% of the amount through sun exposure. Unfortunately, because the new lifestyles and indoor work mostly, and some air pollution in places like India and other countries, the amount of UVB rays getting on to the Earth's surface is much limited. So indoors we get nothing, and the winters you get nothing. Even if you get a full sun exposure during winter period, the amount of vitamin D generated in skin is zero. So let me make it easier by sharing a slide with you, hopefully. This basically is to summarize the whole metabolism of vitamin D from UV exposure to diet and supplements. Irrespective of whether we get a D2 or D3 from the diet, because most of the mushroom and things has got a D2, whereas if you the salmon and other animal ones has a D3. Irrespective of that, D2 and D3 get a conversion in the liver to form 25-hydroxy vitamin D, which is called calcifediol, through the hormone or an enzyme called 25-hydroxylase. But as we discuss later, I hope that we can also, there's a very important process of this happening in target cell, which is not present, shown in this slide. So this 25-hydroxy D, it get further hydroxylate at one position here in front of that through one hydroxylase enzyme, which is present ubiquitously in almost every cells in the body. But until about 10, 15 years ago, we are only knew of the concentrating on the renal cells, renal tubular cells, which converting this 25-hydroxy D to calcitriol, which is actually the hormonal form of vitamin D, which is difficult to quantitate, but we think that it's not no more than the 20-25% entire activity of the vitamin D. So remainder, it's very important, which is 75% of the activity to vitamin D from non-hormonal vitamin D. This is crucially important, as most healthcare workers still doesn't seem to be get that concept. So this non-hormonal form is generated at the peripheral target cell within them. So because the circulatory concentration of calcitriol is about 900-fold lower than what they can get into the target cell. So they have to synthesize locally. That depending on the circulatory concentration of both 25-hydroxy D and D3. So anyway, from there, then it will involve with through the hormonal path, it will the serum calcium maintenance through parathyroid and bone cells, and also feedbackly increase the calcium absorption from the intestine and also renal tubular absorption. So again, that we are clearly talking about a part of the 20%, 25% part of the vitamin D activity. So it's also important to realize that there's a built-in mechanism in the body from skin to liver to all the peripheral cells with a 24 hydroxylase activity. So when a 24 hydroxylase enzyme activated, it neutralized or catabolized the activity of 25D, D3, as well as more importantly, the calcitriol. So that is a major inactivation step to control the feedback mechanisms of these complex pathway.
Yeah, it's a extremely intricate system that the body has developed, and I'm trying to think of a really good analogy again to get people to understand this concept. But essentially, what we've got is this circulating form, and that is the form that you get measured if you go to your primary care doctor, or you get measured on a serum, a venous blood draw. But it needs to be activated, and what Sunil said is that historically or canonically this has occurred only in the renal cells in the kidneys, but what we know now as it relates and is important for immune system function is that all these critical immune cells, macrophages, neutrophils, I'm guessing, and lymphocytes, they also activate the precursor vitamin D on site, and that helps them to have their function. So it's almost like in a war zone, you've got artillery shells all over the front, but they actually have to be put into the howitzer before they can be fired off and be activated. Otherwise, you'd have everything going exploding. So the other interesting point that you made was this inactivation step, and more recently, there was a review released regarding the formation of these other secosteroid compounds, which seem to have related effects to vitamin D, like lumistrol and tachystrol as well.
Yes.
Mm.
The only but the concentration of those metabolites are very small. So even though they have, it can be demonstrate the biological effect in vitro, very difficult to show that in vivo because of a number of reasons. I mean, firstly, you cannot give this kind of unauthorized metabolites to human. Secondly, even if you do that, there's no way of controlling them. So the other
Mm.
point I forgot to mention that to activation of the 7-dehydroxycholesterol, which is natural, it's basically a endogenous compound on the skin. It's activated by the UVB in the range from about 280 to 305. It's a median about 300 nanometers. So this is a crucial thing because second thing actually in the day of in the time of the day, because if you get the UVB rays and the broader angle, and that will not penetrate the system and also reach not reach getting inside the into the skin as well. For example, the best time to be in the sun to get vitamin D is from about 10:30 to 1:30, 10:30 a.m. to 1:30 p.m. because that's the time what you call the zenith angle, the angle between the vertical and the sun rays coming this way is the shortest. Shorter the angle, the higher the penetration of UVBs coming into us and also through the skin. So the extension of that actually to contrary to the previous myths, and if you are recommended by to go to the get the sun exposure in the early in the morning in the afternoon, but we need to be mindful that the amount of vitamin D generated in the morning and in the evening is negligible, maybe zero, close to zero. Similar thing happened in the winter period from about October, end of October to up to about end of April. The vitamin UVB rays does not reach us. So that's the reason basically, no matter how many hours you stay in the sunshine during this period, you do not increase your serum vitamin D levels.
Yeah, very interesting point. And look, the other times of the day are important for a circadian rhythm point of view, and have all kinds of other health benefits that I've talked about previously. But yes, the midday, is prime time for vitamin D generation because of the essential penetration, as you said, of short wavelength light through the atmosphere. Do you have any comment about the sulfation and the process of sulfation of skin generated vitamin D versus perhaps an oral supplement?
Uh, Not much really, because my understanding is not deep enough to make a definitive comment. But these are important areas both for activation and inactivation of vitamin D. Excuse me. And the skin itself is a unique thing because the excess sun exposure will never cause too much vitamin D in the blood. There is a built-in mechanism within the skin. The vitamin D3 get or the precursor itself would get destroyed or 25 hydroxylated, and therefore it prevented getting into the circulation through binding to vitamin D binding protein. So it's an inherent protective mechanism we have. So very important to overexposure to sun, of course, can harm the skin and the DNA, all this stuff if you stay too long. Especially one need to absolutely avoid the sunburns, which can have a long-term consequences, negative consequences. But irrespective of the time, you will never get vitamin D toxicity or higher level of vitamin D in the circulation.
Yeah, that's the point I make clearly to people, which is it's not physiological possible to get hypervitaminosis D from overexposure. And as you said, there's other issues. We push past the hormetic benefit of UV light, if you're going to cook yourself, but hypervitaminosis D isn't one of those. Let's talk about your specialty and your expert domain, which is the role of this system in immunity, because You're going to show us a slide later on, but it feels like clinical medicine is essentially mired or trapped in a paradigm of which is essentially exclusively interested in the bone complications of vitamin D. But what your work and others has showed is that there's a profound role of this compound, this serotonin hormone, in immune function.
Thank you for the question. So it's complicated, but let me to summarize or present on the fairly straightforward manner. So as we discussed a few minutes ago, immune cells function activation is almost primarily 80% of the activity is dependent on the availability of intracellular calcitriol within the immune cells, not in the circulation. So by giving calcitriol as an agent orally or intravenously, very few, or if at all none of them will get into immune cells or the cardiovascular cell, because there's no mechanism for active absorption of calcitriol. So, and also I mentioned that the level of you can achieve with the calcitriol in the circulation is about 900-fold less than that needed to diffuse into immune cells. So that's not going to happen. So immune cells are primarily depending on the circulatory D and 25-hydroxy vitamin D, calcifediol. So level of these achieving and maintaining in the circulation is crucial for all the peripheral target cells for vitamin D, from brain to immune cells. So if you have an intermittent intake of vitamin D, for example, say you should take it once a month or once every other month or once in 2 weeks even, the level become insufficient to get into the immune cells in between the net. So therefore, even if you have immune issues or getting infection, during those periods, immune cells are unable to get activated. That's the importance of getting daily vitamin D3 intake, or at least once a week, because the half-life, as shown, let me show you a slide on the half-life so we can. Oh, okay. So this slide summarizes the half-lives and the normal ranges of three to metabolites and vitamin D itself. So 25-hydroxy-D is the longest partly because it's bound to vitamin D binding protein and lasts longer. And the vitamin D is 24 hours. And that's the reason why need to the physiological rationale of a daily doses are better than intermittent doses. Because as I said a minute ago, vitamin D3 intake and the circulatory level, which you routinely we do not measure, is not available. That has a highest probability of getting into the immune cell compared to 25-hydroxy vitamin D because of the concentration gradient and the affinity to vitamin D receptors. So this is more tightly bound compared to vitamin D. So it's more vitamin D get absorbed. So intermittently, if you give vitamin D, this level would go down intermittently. So that's one of also the reason for some people get adverse effects, so-called adverse effects, like in prostatic carcinoma and pancreatic carcinoma. The circulating big fluctuation are not physiological for human being because we are supposed to get vitamin D from the sun daily exposure. Historically, and if you look at our ancestors, they get a continuous supply of vitamin D. Short active, they do the job. In contrast, 125-hydroxy vitamin D, which is calcitriol, is very short acting. It gets denatures deactivated very quickly. Plus, the concentration here is picograms per milliliters. It's almost 1,000-fold less than D3 and 25. So you can see that why this amount or small amount is unable to get into the immune cell. So giving calcitriol to expecting results is insane. It doesn't happen. It can only cause adverse effect because 125-hydroxy is very active If you raise a level to 100 plus here, you will get a hypercalcemic syndrome. So you're not helping patients by giving this thing. So instead of, you should give the vitamin D or 25-hydroxy D in certain circumstances. We can discuss it appropriately. Major difference is if you give vitamin D, it takes about 3 days to appear in the blood as a 25-hydroxy vitamin D, which is also necessary for renal function, renal activity to a hormone. Whereas if you give calcifediol, which is less hydrophilic, therefore it does not depending on the intestinal lipid mechanism to get it absorbed. Otherwise, it had to go to get absorbed into and ultimately end up in the thoracic duct into the blood system. And then it had to be converted to 25-hydroxy D in the liver the rate limiting step as well. So this process of vitamin D taken into converted into 25D and appear in the circulation take about 3 days, anything from 2 to 5 days. But in sick patient like ICU, this will take 7 to 10 days. So here's the point. And in sick patient in ICU, giving vitamin D, you can give 600,000. It's not going to help them
Mm.
because it will not get into the circulation as a 25 D that is necessary for some additional function because it takes too long. On these circumstances, specifically in acute circumstances like COVID, for example, acute infection. So you can give, if available, calcifediol, very small doses, about 1 milligram calcifediol will do the job. And when orally given 25-hydroxy D calcifediol, within about 4 to 6 hours, it appears in the circulation. It's at a active or semi-active 25-hydroxy D compared to take 3 days in the vitamin D. Eventually, the actions of between two are same. So if it's an acute situation, giving this vitamin D and expected result is not right. We have to, depending on the 25-hydroxy D in things like ICU situation, they should be available for this patient. So one more thing on that. So if you look, yeah, so go
Okay,
ahead.
I was just gonna, if you go back to the slide, I was just gonna quickly summarize for people that what you said, and what essentially is Professor is saying is that there's these three different forms of vitamin D, and the progression from vitamin D to 25 hydroxy vitamin D, which is the storage form and the measured form, and then the final form of 125 dihydroxy vitamin D. These are all separate forms, and the way that they are existing in the blood, or the range that they're existing in the blood, is different and specifically managed. And the point being that if you're taking oral vitamin D, then that will have a half life of 24 hours. It will actually peak and go back down. But if you're having vitamin D generated cutaneously, then the half life is longer because it's binding to the vitamin D binding protein, and therefore keep potentially slowly dripping into the system. And I believe that was a study done by Holick showing irradiation with one minimal erythemal dose of UV light led to 10,000 unit kind of equivalent, but it was a much slower release compared to an orally dosed preparation. And the point being that ideally, as you said, we'd have daily UVB exposure such that we have a slow drip of vitamin D into the system, and therefore a slow drip of 25 hydroxy vitamin D into conversion into 125 hydroxy vitamin D at the end target cell, whether that's the kidney organ, whether that's the brain, whether that's the immune system, it's etc.
Yes, thank you for summarizing. You did very well. So this slide's this last one on this series to show that again, the more important, the concentration in the blood. I can see the nanomoles, whereas a picomoles in with calcitriol. It's very important to understand that. So the difference between what you can achieve and the half lives of these three molecules. So Preferably, what we recommend is to take D3 routinely, but there are specific instances where you can uh, take 25-hydroxy calcifediol. One, as you said, is the acute infections, because that will act within 4 to 6 hours.
Mm,
The second one is that in somebody with a liver failure, which does not produce 25-hydroxy-D, clearly, given that it will be beneficial, you can bypass the liver. So
mm.
on the other cases, the calcifediol is not a replacement for vitamin D. It is 20 times more expensive, and it's unnecessary to give calcifediol when there's no rush, and you can get all the benefit by giving D3.
Can you speak to the clinical evidence for the use of calcifediol in acute illness, say ICU admission? And this other idea that potentially we're trying to assess our patient's vitamin D status. So we take a 25 hydroxy serum measurement. Is that a negative acute phase reactant? Is that going down because the patient is so unwell and because they're essentially consuming up that
A
hormone?
great point, Max. I mean, this again we learned during the last just a few years, really. And there are convincing evidence that any acute illnesses, even the trauma, infections, autoimmune exacerbation, consume significant amount of calcitriol within those immune cells. So this is one way things. Intracellularly generated calcitriol does not come back to or secreted back to the circulation. They get destroyed within the active cells, immune cells. So what is necessary is actually even those circumstances, unless you give them enough substrate, D3 or calcifediol, your immune cell activity continue to go down. For example, if somebody with acute infection admitted and the level could be normal, the D 25-hydroxy-D could be normal, but the consumption of vitamin 25-hydroxy-D and D3 tremendously increased during infection. So unless you give a supply of vitamin from the day one, if you measure the level in day 4, day 5, could be actually going back to the deficiency level. So this is another principle very few people understand and difficult to grasp. So it's part of the, not necessarily part of the acute phase reaction, but the consumption within the immune cells, because they use so much to get it activated, and they deactivated with the 25 hydroxylate enzyme. So to replace that, you need to have a daily supply of vitamin D3 and 25 hydroxy-D coming into the circulation and then moving inside the cells.
And
Good
do we
point.
have some randomized controlled trials, double-blinded or placebo-controlled, showing that patients treated with calcifediol have a better outcome, say in acute respiratory distress syndrome compared to a placebo? Is that data that we have or not? Not really.
Another good question, Max. I mean, during the COVID, there had been at least 10 different randomized controlled trials from different groups had clearly shown that if you give calcifediol, it has a tremendous benefit in the prevention of complications and deaths, about 50% reduction in hospital setup and ICU.
Mm.
But again, the sick patient giving vitamin D, people have shown that even randomized controlled trials, there's basically no effect. The reason is, as I said before, the vitamin D might not even get converted to 25-hydroxy-D uh, to be benefited because their system, whole enzymatic system in the body is not functioning well. So this is a classical example of where people need to be given some very small doses, just 1 milligram of loading dose of calcitriol, and you can actually repeat that in every third day. That will maintain the 25 hydroxy level within the normal range of about 14 nanograms per mil.
Yeah, excellent. And again, I mean, it's a little bit technical, but I think this is extremely important for us to talk about, especially for the doctors who listen to the podcast, which is, we obviously use, or you as an endocrinologist and a renal physicians, they use calcitriol for their kidney failure patients because those patients lack, because of chronic kidney disease, they lack the ability to convert 25-hydroxy-D to calcitriol. So they're obviously giving them that hormone directly.
Yeah, it's absolutely right. So we haven't spoken about the calcitriol specific indication. So as you said, Max, the renal failure is the commonest thing, and everybody knows for the last many decades. So the renal tubular failure will lead to inability to convert vitamin D precursors into calcitriol, the hormonal form. So therefore, when the hormonal form goes down, the musculoskeletal system, parothyroid glands, bones all get deranged. So because they cannot function normally without the level of, without having the calcitriol, 125 hydroxy vitamin D available to them. So having said that, up to about 18 years ago, that's the only treatment the nephrologists used to give to the renally impaired patients, like stage 4, stage 5 renal failure. Since then, there were many studies shown that if you combine the calcitriol with vitamin D, the complication and the survival is significantly increased. That shows the other beneficial actions of what these precursors in these patients. That means also in every other patients which we are missing. So now the current treatment is actually not only provided the calcitriol, but also provided them with a reasonable dose, something like 5,000 to 8,000 international units of vitamin D on a daily basis. Because we know that categorically through randomized controlled trials, their survival and quality of life both improve. The the same thinking, the measurement of 125 hydroxy G is redundant, should not do it because you cannot interpret that data. The only reason for doing the 125 hydroxy assays is in renal failure, or there are very rare genetic disorders of failure of production of 125 due to enzymatic failure in the hepatic mostly. So there is no routine reason for measuring 125 hydroxy D3.
I'm very glad you brought that up because in some holistic health circles, people are advocating for measurement of 125 hydroxy vitamin D. But I think as you've really comprehensively shown, it's not really giving us a very good idea about anything except in the case of severe renal failure because of its tiny circulation, tiny in the circulatory system, and the fact that, as you mentioned earlier, that most of this enzyme and of this hormone is actually being converted on site in the cells when it's being needed. I would be curious myself about a trial of whole body, heliotherapy for these chronic renal failure patients, and whether, in addition to, if we could help them generate massive amounts of solar cutaneous vitamin D and corticosteroids, maybe that could even help improve function and potentially reduce the amount of supplement needed.
So before addressing that one, I think we're going to go back to the previous one, which is not only that 125 hydroxy level is uninterpretable, it's actually misleading.
Mm.
So if you could recall that the second slide I showed that, let's take a step back. So different tissues need different thresholds of vitamin D in human. Not the diseases, it doesn't affect with the age, but different tissues has a different threshold. For example, musculoskeletal tissues, 15 to 20 nanograms per milliliter is more than sufficient to full functioning of the for the human. if you take a step back and then think, why is that happening evolutionary? This is the evolutionary mechanism for saving our human lives. So imagine that you are back to hunter-gathering at the stages. If you don't have a musculoskeletal system to go after animals and eat and kill, and also running away from them, you are dead in no time. So priority in the body is to provide the necessary circulatory calcitriol hormone, compromising all the other systems which are not priority for survival at that time. Therefore, whatever the available 25-hydroxy-D is taken up actively. There is a positive mechanism of extracting 25-hydroxy-D into renal tubular cells. It's called a Mechelin-Kubelin mechanism. So even the little of 25-hydroxy-D available will be extracted from the circulation to renal tissues to convert it to the hormonal form of calcitriol. That's going to do this job. So in those circumstances, if you measure the 25-hydroxy-D, or if one measure that 125-hydroxy-D level could be absolutely normal, but the 25-hydroxy-D could be very low because that active mechanism of extracting 25D into the renal tubular cells. So coming back to the heliotherapy and things, there are a lot of studies going on even now. So it is showing some initial studies show the controversial data, but I think that things are getting better once if people understand what exactly the wavelengths and prevent the harmful wavelengths provided to patient and the duration of exposure, that kind of thing. Uh, things are getting better. You have to remember that no matter how much exposure we have, heliotherapy or sun exposure, we will not get hyper level of vitamin D or 25 hydroxy D in circulation. So that safety mechanism override everything.
Yes, thanks for re-emphasizing that. And a previous podcast guest and founder of MedCram, Dr. Roger Schwelt, who's a intensive care physician in Loma Linda, California, he's had some great results with acute viral respiratory illnesses and with simply just taking his patients outside. And he's got some great videos that on that, the why that is working, and factors not only related to the vitamin D system, but also to near infrared, which is very interesting. I want you to talk about the hypercalcemic syndrome, and I think it's relevant because the threat or the worry about inducing hypercalcemic hypervitaminosis D is probably one of the biggest things that is uh, factors that is preventing my colleagues and probably your colleagues from helping people to get to a healthier vitamin D level. So can you talk about this diagnosis and what it actually means to have too much vitamin D in our system and what that leads to?
If you don't mind if I add one more thing on the previous one. So
Sure.
historically, going back to 100 years now, the tuberculosis and leprosy patient, they were segregated. So the people who were taken into the sunshine or onto the sunshine on the daily basis survived, whereas the rest demise. So they didn't know what curing this patient who exposed to sunshine. So that concept has been there for nearly 100 years, and of course, over the past few decades, we got to know that that's because the conversion of uh, generation of vitamin D in the skin, which does that uh, uh, therapy for these patients. It's similarly, as you said, that it is very important in infection control. So let's come back to the toxicity. Vitamin D toxicity, I would say that's as rare as a hen's teeth, extremely rare. Only 120 cases have been reported in the literature. Almost all of them are due to mistakenly taking very high amount of vitamin D. For example, in Canada, there was the droplets of vitamin D, and they had a 1 million units per ml. So instead of drop taking, those who take 1 ml per day, they had a multiple millions of vitamin D coming into their bodies in short period, and they develop a hypercalcemic syndrome. Secondly, to diagnose hypercalcemic syndrome due to vitamin D toxicity, you need to have at least three specific things. Number one is the circulatory level of 25-hydroxy D should be above 150 nanograms per ml. Most cases about 200, 250 nanograms per ml when you get a toxicity. Secondly, there must be a hypercalcemic symptoms, the dry eyes, cardiac arrhythmias, and various other hypercalcemic syndrome. And third one is hypercalciuria. So once you get all three uh, variables, you can categorically say that, okay, this is probably most likely due to vitamin D. Let's stop vitamin D, and mm, almost always cases with time it will come back to normal. Very few patients needing dialysis, short-term dialysis to remove the ionized calcium. But that's true with any hypercalcemic syndrome. The most commonly is secondary to cancer, head and neck cancers and squamous cell carcinoma. That's not due to vitamin D, but is due to PTH related peptide, PTHRP uh, peptide released from the squamous cell carcinomas. So that's a
The
complete
par
difference, but
the
it can cause a
paraneoplastic,
life-threatening conditions. Yeah,
the paraneoplastic syndrome.
yeah, exactly.
Yeah. Yeah. The point is, and I'm going to convert to Australian units, 150 nanograms per mil is going to be above 300, 350 nanomoles per liter, again, as this threshold for toxicity. And I'm not advocating that people are using, ultra high dose supplementation. Like my preference is always that people build their serum vitamin D naturally. But even on our reference ranges, I've heard of lots of people who've naturally had levels of 180, even over 200 just from solar exposure, and their doctors have said, hey, what are you doing? Stop doing whatever you're doing. And as you've clearly laid out for us, Sunil, this patient is so far away from a hypercalcemic syndrome. One is because they're not even supplementing, so no matter what that level is, they're not at risk of hypercalcemia because it's cutaneously generated. And two, even if they were, without high serum calcium, without hypercalciuria, without symptoms of hypercalcemia, then this patient doesn't meet the criteria and is therefore not at risk of a complication of having too much vitamin D in the system.
Yeah, I mean, in generally, there's no reason to get alarmed with that kind of numbers. I mean, even the normal range in US is the upper limit is 100 nanograms per milliliter, which is 250 nanomoles per liter. So there's only one or two exceptions with the sensitivity to um, vitamin D. One is a Williams syndrome, for example, is a genetic disorder. So those with the Williams syndrome and they have a hyperactivity to on generating and maintaining high level of vitamin D, which is extremely small number of patients. This, so I think it's a hypercalcemic syndrome secondary to or vitamin D toxicity itself is hyped due to number of reasons, mostly political, and big pharma had been amplifying the stories, just like happened with ivermectin during the COVID period.
Mm. Let's talk about the breadth of issues that are potentially ameliorated or prevented by vitamin D repletion. So we've obviously, and you've got a very good slide on this. At the base level, we've talked about bone complications, and in children, that severe vitamin D deficiency causes rickets, and people might have seen pictures of children with bowed legs, bowed femur, and tibia fibia, and that's through having a lack of vitamin D. And then in the adult, we get dysplasia of bone formation, which is called osteomalacia. and long term contributes to osteoporosis or thinning of bones. But as you alluded to, Sunil, this is really just the tip of the iceberg. Above that, we've got these muscle functions, and it's very interesting to me that you can prevent falls in the elderly by simply just raising their their vitamin D level. And how many athletes out there could optimize their musculoskeletal function with by raising their serum vitamin D levels? But talk us through the next steps incrementally as we raise the serum vitamin D level and what disease processes that is preventing or ameliorating.
Right. So interestingly, over the few decades of my clinical practice, I have seen many wheelchair-bound patients brought to me for various reasons. And when we treat them with a high-dose vitamin D, we generally give at least 200,000 as is a bolus dose and 50,000 a week. Within about a week, 2 weeks, many of these patients starting walking. It's not a miracle. Most of them had a severe osteomalacia with the pelvic and the girdle weaknesses, so they cannot comb their hair or eat. They're very weak shoulders. They cannot get from the bed or chair because of the pelvic muscle weakness. So these will get rectified within days of adequate supply of vitamin D. When I say adequate supply, not given by 5,000 or 10,000, they need the starting dose about 200,000 or 100,000 at least to begin with
Wow.
to replenish their stores, and they'll have remarkable recovery from their illnesses. So let's see. Similarly, as we said, the most of the diseases, as I mentioned here, this slide basically it shows that this is a serum level of vitamin D, 25-hydroxy D in nanograms per mil. For Australian levels, you need to multiply by 2.5 times. So 15 to here's above 80. That's a separate category. You just forget about for the time being. And here on this x-axis on the right side, I showed is a reported percentage risk reduction or improvement or getting rid of the symptom. You can see that in calcium metabolism, skeletal issues like rickets and osteomalacia, there's a 90% recovery within weeks of
Mm,
getting the level up to 20 nanograms per mil. For
mm,
example, others, osteoporosis, fracture prevention, inflammatory bowel disease, which is immunological disorder, they need a little bit higher. So obesity, diabetes, and some of the cardiovascular disease, they need 40 nanograms per mil. These are tissue threshold where the vitamin D can get into the relative responsive peripheral target cell. In
mm,
autoimmune disorders like multiple sclerosis, as well as acute infection, they need a lot more higher, minimum of 50 nanograms per mil. So this is the categories we're talking about 1% or less of the population who has a vitamin D resistance syndromes. Generally preferable to treat by the expert who can handle higher dose of vitamin D, like Coimbra protocol, and there are 2 or 3 very high dose vitamin D protocol, but it must be administered by somebody in a center or somebody who knows how to handle this and prevent adverse effects. But these disorders like cluster headaches, migraine, some will respond dramatically when the level were raised higher than 80 nanograms per mil. Some of them actually to up to about 150 nanograms. But this is not for routine practice for primary care or the GPs. Please don't try to do that because that you can get into issues. So basically, this slide shows that there are different thresholds for vitamin D for different tissues. However, it's also important to note that there's no differences in threshold for male, female, or young versus old, or sick versus healthy. That doesn't change. So what we need is to have the minimum level to accompany or actually to take care of at least 95%, 98% of the disorder, which is 50 nanograms per mil. 40 nanograms per mil also okay. That covers about 80% of the disorders. Whereas calcium metabolism, 15 nanograms will only take care of the calcium and, sorry, the skeletal musculoskeletal disorder, which is about 25% of the issue. So people asking what should be the normal range. So depending on the interest of the group or conflict of interest, they say, okay, 20 is enough, like Institute of Medicine did, because they were only focusing on the rickets and osteomalacia. Even then, they made a huge blunder, uh, a statistical mistake by missing a decimal point, and instead of 600 milligrams of calcium, instead of 6,000, they actually recommended 600. They made a huge issue. That causes really problem for the subsequent, all the guidelines, because they are all relying on the Institute of Medicine guideline, which
Mm,
are therefore every other guideline came after that were completely screwed, because they are all catering for musculoskeletal only. Only now
mm.
people are beginning to realize that that's the mistake. We need to get out of it, and we need to revise the guideline to cover these disorders. Otherwise, they'll be not even touched.
Yeah, and 40 nanograms per mil again to for the UK and Australian listeners, that's 100 nanomoles per liter. So that's commonly one that I just say to my patients, like, I mean, at least let's try and get you over 100, and let's get you at least over 40. Again, ideally through natural sunlight exposure, um, as a first line, because we're going to hope will prevent so many issues. And I was talking to a clinician, and the rheumatologists or the immunologists who are treating, sorry, the neurologists who are treating multiple sclerosis, they, as a rule, they want their patients over 100. So it's almost like certain specialties within medicine have realized that if their patients go below these levels or above certain levels, they do better. Yet for some reason, it's not universally acknowledged because of siloing in medicine. And I'm interested to hear your thoughts on that. But the truth of the matter is that if we get above some of these thresholds of 25 hydroxy D, ideally through natural exposure, then we're going to prevent so many of the chronic diseases that are affecting us as today in society.
I give one example of, so this is about 2 or 3 decades ago in our clinic, my clinic. We had something like a 70 plus multiple sclerosis patients coming to us on various issues. And uniformly, their level were about 5, 10, 20 is a max. So in my clinic, we opted to change that and to wanted to keep the level above 80. Within months, you'll be surprised that recurrence rate of my multiple sclerosis reduced by 80%. So instead of coming every 3 months for various ailment, now they're coming once a year. You don't need to. All because we are now providing the enough vitamin D to immune cells so that autoimmunity can be controlled within themselves.
And you, in one of your review articles, you really eloquently described what is actually going on when we're vitamin D replete versus deficient. And I've explained it to my patients as in a simplistic way, is that when you're vitamin D deficient, your immune system has its fists up and it's ready to fight, essentially ready to fight itself, and therefore putting you at risk of autoimmune conditions. And that is also the latitude gradient, the UV latitude gradient that we see in autoimmune disease because of the lack of availability of vitamin D generation or sun exposure, sun-seeking behavior. The further down away from the equator you go, the higher MS and type 1 diabetes and these diseases rise. But you put it really eloquently in your review article when you describe this vitamin D system as almost a switch that's turning the immune system from pro-inflammatory, if you're deficient, to essentially immune tolerant and anti-inflammatory when the patient's vitamin D replete.
Yeah, it has been now described over the last 10 years by many research groups. The phenomena what you mentioned it. For example, Th1 cell to Th2 cell, that transfer will not happen unless there is a sufficient vitamin D, active vitamin D within cell. Same with the Th17 cells. So in a vitamin D deficient status, these active immune cells will remain in the inflammatory setup. So continue to produce inflammatory cytokine rather than anti-inflammatory cytokine. So in the presence of sufficient vitamin D, so Th cells, Th1 convert into Th2 cells, then that alone will prevent the generation of an inflammatory cytokine and start to generate more protective anti-inflammatory cytokine. So this thing happened on multiple sites or the mechanism within the immune cells. So this is another one area, the switching necessary for vitamin D to immune cell to do what it's supposed to do rather than harming us by generating autoantibodies.
Yes. Well, let's talk about dosing now, and how do you approach the topic of dosing, and talk about perhaps some of these cofactors that are necessary or required in the metabolism of vitamin D as well.
Yeah, so the recommended doses by the government and most societies is 400 to 600 milligrams, international units on a daily basis, which barely change the serum level of vitamin D. So I told you the reason because they mess up with the conversion from statistical error. So generally, what we do is if there's a no emergency or the patient is not sick, you can start the normal replacement therapy of vitamin D. What we recommend is actually this is after analyzing over 500 published data on 25-hydroxy D and how it affects the various systems. So we come up with the formula to give between 70 to 90 international units per kilogram body weight for non-obese person as a replacement dose. Very easy to calculate, very easy to remember. You don't need charts and things. Even though in but 2-3 years ago we published a detailed tables how to calculate an individual basis. That's cumbersome, but it's helpful. But if you remember to use mentally calculate 70 to 90 international units per kilogram basis, that is the amount necessary for maintenance. However, people with obese, overweight, and those who are with the other disorder, comorbidities, or taking uh, medication that increase hepatic catabolism of vitamin D, like retroviral drugs or anti-epileptic drugs, they are going to need about 3, maybe 4 times higher than these doses to maintain the serum level of 25-hydroxy between 40 and 80 nanograms a mil. So it's a concept that sometimes going to take a little while to understand, but it works and very easy to remember and use in clinical setups.
And in terms of the dosing, we talked briefly about how we essentially want to maintain a constant supply, like a drip of vitamin D into the system, so it can be readily and accessibly converted to calcitriol. I think of this like and I think also about this during gestation and pregnancy with respect to all micronutrients, is that it's like you want the shelf on the supermarket to always be full. You don't want there to be a period where you've got an empty shelf where you can't restock. You always want there to be enough. And so what is the daily recommendation? Again, I'm going to preface this with I recommend people get solar generated D if they can as a first port of call, and they can use an app like a DMinder to kind of track that or estimate the amount that they're making. But if say that they're supplementing and say they've got a critical illness or they've got a severe autoimmune disease, what would you recommend in terms of dosing frequency?
I totally agree with you. Whatever it is a daily is the best option. If you can't remember to take daily or it's a cumbersome, then once a week is a second best option. Both works pretty well. But if you increase the frequency beyond twice a month, it's actually not helping. There are studies done with the giving a very large dose of vitamin D on every 6 monthly, 3 monthly, or annually. None of them showed any benefit. In fact, annual treatment has shown actually significant negative effects like increased falls and fractures. That's understandable because when you give the large doses to somebody deficient, transiently that person become vitamin D sufficient. So their function become good. So they started walking straight away and they're going to have falls because they don't have the balance it out. So that's the reason for increased fractures and falls, not because of the vitamin D toxicity, because
Interesting.
they try to run before they can stand up. So that way. Let me also mention before I forget that the dose of calcifediol, which we have published in about 3 years ago. So again, very easy to calculate. And if you remember to 0.014 milligrams per kilogram body weight, an average person is come to about 1 milligram basically. So 0.014 milligrams per kilogram body weight is a standard dose you can give to anybody to raise their serum 24 hydroxy level within 4 to 6 hours to a given condition. So it will cover that.
Amazing. And maybe that's one for the general medicine physicians, the internal medicine physicians who are treating their inpatients. Get your pharmacy to stock calcifediol. And if you're having someone coming in with a lobar pneumonia or another sepsis, I mean, it sounds like a very cheap and safe intervention to, yes, treat them with intravenous antibiotics, but why not treat them as well with calcifediol if you can't, which most people can't, put them out on the porch on in the sunlight.
So in this regard, so the calculate very detailed calculation we have made on different models and the
Mm.
cost benefits of vitamin D prophylactically using is about 1 to 10,000. So if you spend $1 in to treat with vitamin D, you get it close to $10,000 worth of prevention because these patients are getting into vitamin D deficient patients are getting into various complications, diabetic, asthma, GI, neurological. So if you look at the test needed to these patients like MRIs, etc., hospitalization, those, if you do the detailed analysis, is a huge cost benefit of providing vitamin D. In addition, the recent work we have done on occupation point of view, it shows that it significantly reduced the absentees and improve the work efficiencies. So I suggest that the companies and the directors and the owners of these large businesses think carefully and see whether they what benefit they can get by making their working population vitamin D sufficient, which costs virtually nothing. And even with or without the testing 25 hydroxy D, testing is recommended but not essential. By doing so, they can see that the difference within 6 months of productivity and the reduction of absentees. So that, in other words, the opportunity cost reduced dramatically in these patients in these
Can you
circumstances.
that would makes sense to me. Can you speak to the use or the co-supplementation with vitamin K2 and this idea that potentially if we are supplementing in isolation vitamin D, the possibility of adverse cardiac calcification effect?
Yes, sure. The vitamin K is one you're referring to. Although vitamin K has no direct effect or enhance activity of vitamin D, it's supposed to divert that excess calcium, if any. I'm talking about the ionized calcium in the blood towards the bones. So just like osteocalcin, then that kind of thing to absorb the serum excess calcium into that. But generally, unless you're taking anything more than 7,000 international units per day, you are not needed to have vitamin K2. But taking K2 is no harm. The amount of K2 we recommend is about 100, 150 microgram per day. Or there are once a week capsules. This comes up with the 800 micrograms per capsule. So, for example, if you're taking 50,000 unit capsules together with the one capsule of K2 of 800, that will be 100% to protect you from any potential of calcification issue. So the second most important nutrient or the supplement you need for activity of the vitamin D, and particularly the receptor interaction as well as several coenzyme activity, is magnesium. So in the magnesium deficiency, vitamin D, many of those hormones work properly. If you look at the thyroid hormones to insulin to testosterone, sex hormones, their release is depending on the availability of certain intracellular amount of magnesium. So as a vitamin D interaction with the VDR, vitamin D receptors, as well as a chromatin interaction need magnesium. So just by increasing the vitamin D dose, say if you give about 50,000 once a week or 6,000 a day, if the person is magnesium deficient, you may not see the benefit as you expected. So in addition, there are other things like a whole bunch of other things like omega-3 fatty acids, zinc. Uh, they are all cofactors that facilitate activity of most of the enzyme, but not necessarily vitamin D. But holistically, for a person to function well, all these cofactors are going to be necessary as well.
Yeah, and very interesting point. And anecdotally, I've heard of people who have supplemented or they've commenced high dose vitamin D supplementation and then found themselves getting cramps. And I think that speaks to the need to ingest the magnesium potentially with that. Do you have any recommendations on preparation or dose or route of administration of that magnesium?
My best recommendation is take a banana a day, maybe two a day. That will provide about 200 milligrams of vitamin D, magnesium necessary. If you
Mm.
can, or if you don't like bananas, you can take the over-the-counter magnesium, 200 to 300 milligrams on a daily basis, or even every other day. That definitely going to be helpful, right? Rather than taking nothing. Because most of the Western diets are deficient in magnesium.
Yes. Are you aware of any and again this is a question related to the fat soluble hormone nature of vitamin D. Are you aware in the literature of any interaction with the vitamin A system and whether supplementing higher doses of vitamin D perhaps in might be unyoking or disturbing a relationship between of vitamin A and vitamin D?
Only literature I have seen and understood is actually high vitamin A intake. It definitely can interfere with the vitamin D metabolism.
Mm.
So so the balance between the vitamin D and vitamin A are necessary. But someone getting a super high dose of vitamin A, you need to be careful because not only the vitamin D interaction, it also can interfere with the bone mineralization and indirectly increase increase the likelihood of developing osteomalacia and other bone disorders.
Yeah, and that I mean, no one is recommending high dose vitamin A supplementation, so that's I think we should make that clear that synthetic vitamin A, retinoid supplementation is not anything that I'm advocating for, and we know that these retinoid medications like isotretinoin are potently teratogenic, so we'll make that abundantly clear. So, um, that's a very good kind of summary of the topic. And do you have any other qu points that you would like to raise about the topic?
Um, yes and no. I mean, you have to be careful on what's happening in some country. Actually, in Australia also, the government is trying to regulate minerals and supplements. nutrients basically. So that is showing that it's a control mechanism for politicians or whoever the people to own, and should natural food or minerals and supplements should never be regulated by the government. That can always cause problems rather than helping. As I said before, there are very small category of people who are going in very high doses of vitamin D. They are mostly either vitamin D resistant disorders or resistant to other drugs like asthma, for example, or migraine headache does not respond to the standard therapy. They'll have cluster headaches. They will get a remarkable response if you raise the level, but that need to be done by the experts, not endocrinologists generally, but somebody who have expertise of handling how high doses of vitamin D. Secondly, those who are taking vitamin D, there's no reason to take calcium supplement because vitamin D itself, if you're having a sufficient amount of dose and level between 30, 40, and 50, that should increase the fractional absorption of calcium from the intestine and automatically get adjusted to the appropriate level of absorption. Therefore, you don't need to. In fact, we should not take excess calcium, extra calcium when you're taking a sufficient vitamin D. So it's not a routine, or we generally discourage to taking calcium supplement the people who are taking vitamin D, except in the case of pregnancy and lactation, because the requirement of calcium goes up tremendously for fetal transfer and calcification of their fetal bones. Other than that, there's nothing specific for to restrict the taking vitamin D. Finally, the effect of vitamin D through the immune system, not only the both adaptive and suppressing immune system, and they generate a lot of antimicrobial peptide like the LL22 and things to protect the human being. So the physician need to think about the optimizing vitamin D on people who are coming with any infection or autoimmune disease, because that might really helpful rather than getting into the high end in the antibody therapies and that kind of thing, which is usually unnecessary.
Yeah, I mean, that's such an important point. And the way that medicine is going now is that there's a new monoclonal antibody flavor for, every single new cytokine under the sun. And yet the basics aren't being done. The patient isn't getting basic advice about ideally full body sun exposure, generating and maintaining a high serum vitamin D level, supplementation if that's not possible, maintaining an aligned circadian rhythm. I know it's not your area of research, but we know that the circadian clocks are regulating immune system function as well. So if people are exposed to artificial light at night, they're suppressing melatonin, then they are also going to be hamstringing their immune system function. Yet, none of very few of our colleagues are discussing this in terms of giving their patients the full advice to optimize their immune system and their health.
I 100% agree with that. The natural therapy, immune regulation using the supplement or the diet itself is the best way to do that rather than getting injection and all the other cocktails available or recommended by various pharmaceutical organizations.
And maybe a final question, because I really enjoyed this in one of your research articles, was this idea of study designing a study to essentially have a null finding. And what I mean by that is that there's this immense pressure from the pharmaceutical industry towards the generation of novel therapies. And the reason for that is because if it's novel, then it can be patentable. And if it's patentable, it's a profit generating source. So the corollary is that if there's an effective generic medication or supplement or hormone, then it's in the interests to essentially reduce or denigrate the efficacy of that compound. And one of the ways that you describe in one of your review articles that this can be done is by simply if say we're testing the role of vitamin D in a disease outcome, is simply recruiting a whole bunch of people that aren't vitamin D deficient. So you give them vitamin D, nothing happens. Well, was it because the vitamin D didn't work, or because they were vitamin D replete?
You're absolutely right again. I mean, if you look at the last six major, what I call the mega vitamin D studies, sponsored by governments and the industry together, like the vital study, for example, and there are several of them, seven of them. So if you look at their recruitment, the more than half of the patients now vitamin D is sufficient on their own guidelines. So what can you expect to give vitamin D 2000 unit, which is nothing, to somebody already sufficient in vitamin D? It doesn't do anything. So that's one way of showing that vitamin D has no effect. So these are what I call it the design to fail studies. I don't know,
Yes.
the deliberate to, for the ignorance. There are many examples that, secondly, they allow the study participant to take over-the-counter medication. And many of the taking vitamin D supplements over the counter and also multivitamins, they has about 1,000 units of vitamin D.
Yeah.
So in active groups and the placebo groups, then the placebo groups now come up with a 20 nanograms per meal. Now they have a 30 nanograms per meal. So how can you differentiate the two groups? Because they are equal now, providing the same ingredient. So there are several of them. I'm just telling the key ones. And next one is actually to the failure of the measuring the baseline vitamin D and on recruitment. So when you do that, you only should recruit the people with vitamin D deficient.
Mm.
Again, on our recent nutrient review paper, I showed and demonstrated that ideal group for clinical studies, randomized control or otherwise, is the middle of those groups, not the severely deficient. Because severely deficient group, if you give 5,000 of vitamin D, it takes about 1 year for them to raise their level. It's not going to work unless you give a loading dose of 200,000 units. Then you can bring them to up to speed and give a daily dose. They will respond very well. Secondly, one should never use the towards the end of the plateauing of the curve on the top, where they are near normal or normal itself. By giving more will not produce anything good. Principle is vitamin D, just like many other nutrients, they are they are saturable groups. So that way, once you saturate the receptors or that reaction, giving more has no beneficial effect. They can even have a side effect. So there are many poorly designed studies. Many has got many of them. And another one is actually to failure to mention the serum 25 level achieved, which is your goal. You
Yes.
should have a targeted level to be achieved. If you can give a 5,000 unit and achieve a 50 nanograms per mil, forget it. It's not going to happen. So
Yeah.
if you want to do that, then you need to measure at the beginning and at least 3 to 4 months later into the study to make sure that they are all on the above the target level of vitamin D. Without that, just simply to correlate the dose of vitamin D to outcome is insane because every
It's
patient,
just
every person is different and their
yes.
metabolism is different. So two people, even it's the same weight, if you give 5,000 unit, they will have different serum levels because they are different.
It's just such poor science, and to me, it evokes your thoughts of anti-competitive behavior. I mean, in any industry, there's anti-competitive behavior, but what essentially it appears that the pharmaceutical industry does is simply weaponizes the randomized control trial. It weaponizes science to essentially knock off competitors, which in this case can be, say, vitamin D supplementation, or there's a whole bunch of other cheap generic off-label off-patent medications that we won't discuss here, but for some people will you can read between the lines. You just do this junk science, and then you've got a null finding, and then you can say to people who don't read into the depths of the study design that this doesn't work, and then you can therefore write everyone off as a quack or anti-science if they believe in that. So, that's my two cents of cynicism with respect to study design.
Wait, let me make a couple more points to add to that. During the COVID period, we saw that how the 2020 and 2021 neglected the generic agents like vitamin D, ivermectin effect, despite having 100 plus clinical trial on these two agents alone, and they're showing that the efficacy is more than 50% reduction of the hospitalization and the death. And the two patented drugs in the like the vaccine and the antiviral agent, they only had the reduction of the hospitalization. They did not have the death reduction of any of those studies getting the approval. Here's vitamin D. There are 100 plus studies, 113, I think, with about 30 plus randomized controlled trials showing every study properly designed showed a reduction of the death rate by about 50%. Costs nothing. And finally, the major mistake done by virtually most of these big universities, for example, getting the mistaken of the nutrient difference between the nutrient and the pharmaceutical agent. Those transpose curves are very different. Nutrient has dose response are going to about a 2 log range, whereas the pharmaceutical agent is very short, very rapid. So we and others have published multiple the review studies showing that randomized control trial is the wrong way to use to show the efficacy of any nutrient, including vitamin D. But they
Interesting.
use that to discredit vitamin D. The randomized control trials are designed specifically by the industry to get the approval of medication, synthetic medication, and vaccines extra to get approval, regulatory approval, not
Yes.
anything else. Whereas nutrient behaves differently, their pharmacological pharmacokinetics are different, and RCTs are the least important or the useful way of testing the efficacy of nutrients. So as actually the Mendelian randomization studies should not be used for nutrient studies because they are distance from the measurement to the current is way too far to have any beneficial effects on the nutrient you can demonstrate using the large databases.
Yeah, I mean, isn't it just a call to get back to the patient in front of us and get back to an n equals one experiment? And the anecdote that's been again written off by this, I would call it this praying to the church of the randomized control trial. We need to go back to uh, practical, common sense interventions, and if we've seen in a clinical setting people improving with, say in your case, the host of MS patients that we've raised their vitamin D level, let's use that and our clinical judgment to help our patients rather than discounting or discrediting potential beneficial safe treatment options because of XYZ conflicted studies said that it was not efficacious, but it was again a flawed investigation. So maybe we can finish with this summary slide that you've prepared, Professor, and then we can wrap up.
So this slide basically summarizes the vitamin D, what happened in vitamin D deficiency. The point is to illustrate that it affects virtually every system. In deficiency, it harms the pregnancy complication goes up, infants, there even IQ with the kids get affected when the mother is vitamin D deficient. Then musculoskeletal disorders, we knew that for uh, decades, and is again coming back. The records is coming back in certain countries due to faulty policies. Then all the chronic diseases are getting worse in the presence of vitamin D. And some chronic diseases actually can manifest as a result of vitamin D deficiency. And non-traumatic acute illnesses mostly the infections and autoimmune diseases, things get initiated and as well as aggravated in vitamin D deficiency. Again, these two obvious ones, the metabolic disorders like obesity, diabetes, all get worsened in the presence of metabolic the vitamin D deficiency. The other side of the coin is when you have these deficiencies and if you treat them properly or supplement them properly or get the heliotherapy to increase the serum level, they all get better and virtually has virtually no side effects demonstrable in these circumstances.
Yeah, fantastic. Well, let's wrap up, and I really like to end with some actionable advice for people. And I think, based on what you said, targeting 70 to 90 international units per kilogram of body weight, and I will say preferably if you can do that through solar exposure, and if not through supplementation, and potentially to use K2 if you're supplementing over 7,000 units per day. And if you're obese, then you need maybe double or even triple that. And likewise, if you are severely unwell, and also for internal physicians and people who are treating sick patients to consider obviously putting your patients outside, but if not, supplementing with calcifediol at a dose of 0.014 is it milligrams per
Milligrams per
kilogram.
kilogram. Yeah.
Yeah. Fantastic. Anything else to add? And if not, let us know, Sunil, where people can follow your work and what. Yeah.
Yeah, we publish useful articles and the suggestions in our LinkedIn at
Okay.
SJ Wimalawansa as well as X and Facebook.
Okay. Well,
And also, the
Professor.
articles are actually published also in the ResearchGate site and Google Scholar. You can also pull them up.
Okay, I'll include them in the YouTube show notes so people can click on those research papers and read them for themselves. So, Professor Wimalawansa, thank you very much for your time. We very much appreciate it, and I think a lot of people are going to get some very interesting and useful information out of the discussion. So, thank you.
You're welcome, Max. Thank you.
Question was about melatonin interactions and this idea that for populations that essentially migrated to northern latitudes during winter, they would have significantly less or no vitamin D signaling. And are you aware of literature or the phenomenon of melatonin kind of analogously working in on vitamin D receptors to potentially compensate during wintertime for an absence of UVB light?
Yes, Max. And there are a lot of literature came up over the last about 3, 4 years. And melatonin has the PMC or POC gene and its byproducts, whole bunch of things. Melatonin is just one of them. How they interacts with the different metabolic pathways and helping the human being. So there are a lot of things going on. Some of them you already summarized, and the interactivity and the interaction with the vitamin D receptors, as well as other cofactors, to bring them together. The other side is that this lack of circadian rhythm causes exactly the opposite. So causing diseases and things because we are not harmonizing our system is supposed to work coalition with all the other nature and the natural things.
Yeah, yeah, amazing. And maybe a final question, because I really enjoyed this in one of your research articles, was this idea of designing a study to essentially have a null finding. And what I mean by that is that there's this immense pressure from the pharmaceutical industry towards the generation of novel therapies. And the reason for that is because if it's novel, then it can be patentable. And if it's patentable, it's a profit generating source. So the corollary is that if there's an effective generic medication or supplement or hormone, then it's in the interests to essentially reduce or denigrate the efficacy of that compound. And one of the ways that you describe in one of your review articles that this can be done is by simply, if say we're testing the role of vitamin D in a disease outcome, is simply recruiting a whole bunch of people that aren't vitamin D deficient. So you give them vitamin D, nothing happens. Well, was it because the vitamin D didn't work, or because they were vitamin D replete?
You're absolutely right again. I mean, if you look at the last six major, what I call the mega vitamin D studies, sponsored by governments and the industry together, like the vital study, for example, and there are several of them, seven of them. So if you look at their recruitment, the more than half of the patients are vitamin D sufficient on their own guidelines. So what can you expect to give vitamin D 2000 unit, which is nothing, to somebody already sufficient in vitamin D? It doesn't do anything. So that's one way of showing that vitamin D has no effect. So these are what I call it the design to fail studies. I don't know,
Yes.
the deliberate to, for the ignorance. There are many examples that, secondly, they allowed the study participant to take over-the-counter medication. And many of the taking vitamin D supplements over the counter and also multivitamins, they has about 1,000 units of vitamin D.
Yeah.
So in active groups and the placebo groups, then the placebo groups now come up with a 20 nanograms per ml. Now they have a 30 nanograms per ml. So how can you differentiate the two groups? Because they are equal now, providing the same ingredient. So there are several of them. I'm just telling the key ones. And next one is actually to the failure of the measuring the baseline vitamin D and on recruitment. So when you do that, you only should recruit the people with vitamin D deficient.
Mm.
Again, on our recent nutrient review paper, I showed and demonstrated that ideal group for clinical studies, randomized control or otherwise, is the middle of those groups, not the severely deficient. Because severely deficient group, if you give 5,000 vitamin D, it takes about 1 year for them to raise their level. It's not going to work unless you give a loading dose of 200,000 units. Then you can bring them up to speed and give a daily dose. They will respond very well. Secondly, one should never use towards the end of the plateauing of the curve on the top, where they are near normal or normal itself. By giving more will not produce anything good. Principle is vitamin D, just like many other nutrients, uh, they, they are they are saturable groups. So that way, once you saturate the receptors or that reaction, giving more has no beneficial effect. They can even have a side effect. So there are many poorly designed studies. Many has got many of them. And another one is actually to forget failure to mention the serum 25 level achieved, which is your goal. You
Yes.
should have a targeted level to be achieved. If you can give a 5,000 unit and achieve a 50 nanograms per mil, forget it. It's not going to happen. So
Yeah.
if you want to do that, then you need to measure at the beginning and at least 3 to 4 months later into the study to make sure that they are all on the above the target level of vitamin D. Without that, just simply to correlate the dose of vitamin D to outcome is insane because every
It's
patient,
just
every person is different and their
yes.
metabolism is different. So two people, even it's the same weight, if you give 5,000 unit, they will have different serum levels because they are different.
It's just such poor science, and to me, it evokes your thoughts of anti-competitive behavior. I mean, in any industry, there's anti-competitive behavior, but what essentially it appears that the pharmaceutical industry does is simply weaponizes the randomized control trial. It weaponizes science to essentially knock off competitors, which in this case can be, say, vitamin D supplementation, or let's. There's a whole bunch of other cheap generic off label off patent medications that we won't discuss here, but some people will you can read between the lines. You just do this junk science, and then you've got a null finding, and then you try and you can say to people who don't read into the depths of the study design that this doesn't work, and then you can therefore write everyone off as a quack or an anti-science if they believe in that. So, that's my two cents of cynicism with respect to study design.
Wait, let me make a couple more points to add to that. During the COVID period, we saw that how the 2020 and 2021 neglected the generic agents like vitamin D, ivermectin effect, despite having 100 plus clinical trial on these two agents alone, and the showing that the efficacy is more than 50% reduction of the hospitalization and the death. And the two patented drugs in the like the vaccine and the antiviral agent, they only had the reduction of the hospitalization. They did not have the death reduction of any of those studies getting the approval. Here's vitamin D. There are 100 plus studies, 113, I think, with about 30 plus randomized controlled trials showing every study properly designed showed a reduction of the death rate by about 50%. Cost nothing. And finally, the major mistake done by virtually most of these big universities, for example, getting the mistaken of the nutrient difference between the nutrient and the pharmaceutical agent. Those response curves are very different. Nutrient has dose response are going to about a 2 log range, whereas the pharmaceutical agent is very short, very rapid. So we and others have published multiple the review studies showing that randomized control trial is the wrong way to use to show the efficacy of any nutrient, including vitamin D. But they
Interesting.
use that to discredit vitamin D. The randomized control trials are designed specifically by the industry to get the approval of medication, synthetic medication, and vaccines extra to get approval, regulatory approval, not
Yes.
anything else. Whereas nutrient behaves differently, their pharmacokinetics are different, and RCTs are the least important or the useful way of testing the efficacy of nutrients. So as actually the Mendelian randomization studies should not be used for nutrient studies because they are the distance from the measurement to the current is way too far to have any beneficial effects on the nutrient you can demonstrate using the large databases.
Yeah, I mean, isn't it just a call to get back to the patient in front of us and get back to an N equals one experiment? And the anecdote that's been again written off by this, I would call it this praying to the church of the randomized control trial. We need to go back to uh, practical, common sense interventions, and if we've seen in a clinical setting people improving with, say in your case, the host of MS patients that we've raised their vitamin D level, let's use that and our clinical judgment to help our patients rather than discounting or discrediting potential beneficial safe treatment options because of XYZ conflicted studies said that it was not efficacious, but it was again a flawed investigation. So maybe we can finish with this summary slide that you've prepared, Professor, and then yeah, we can wrap up.
So this slide basically summarizes the vitamin D, what happened in vitamin D deficiency. The point is to illustrate that it affects virtually every system. In deficiency, it harms the pregnancy complication goes up, infants, there even IQ with the kids get affected when the mother is vitamin D deficient. Then musculoskeletal disorders, we knew that for uh, decades, and is again coming back. The records is coming back in certain countries due to faulty policies. Then all the chronic diseases are getting worse in the presence of vitamin D. And some
Mhm.
chronic diseases actually can manifest as a result of vitamin D deficiency. And non-traumatic acute illnesses, mostly the infections and autoimmune diseases, things are get initiated and as well as aggravated in vitamin D deficiency. Again, these two the obvious ones, the metabolic disorders like obesity, diabetes, all get worsened in the presence of metabolic the vitamin D deficiency. The other side of the coin is when you have these deficiencies and if you treat them properly or supplement them properly or get the heliotherapy to increase the serum level, they all get better and virtually has virtually no side effects demonstrable in these circumstances.
Yeah, fantastic. Well, let's wrap up, and I really like to end with some actionable advice for people. And I think, based on what you said, targeting 70 to 90 international units per kilogram of body weight, and I will say preferably if you can do that through solar exposure, um, and if not through supplementation, and potentially to use K2 if you're supplementing over 7,000 units per day. And if you're obese, then you need maybe double or even triple that. And likewise, if you are severely unwell, and also for internal physicians and people who are treating sick patients to consider obviously putting your patients outside, but if not, supplementing with calcifediol at a dose of 0.014 is it milligrams per
Milligrams per
kilogram.
kilogram. Yeah.
Yeah. Fantastic. Anything else to add? And if not, let us know, Sunil, where people can follow your work and what yeah.
Yeah, we published useful articles and the suggestions in our LinkedIn at
Okay.
SJ Wimalawansa as well as X and Facebook.
Okay. Well,
And also the
Professor,
articles are actually published also in the ResearchGate site and Google Scholar. You can also pull them up.
okay, I'll include them in the YouTube show notes so people can click on those research papers and read them for themselves. So, Professor Wimler wants to thank you very much for your time. We very much appreciate it, and I think a lot of people are going to get some very interesting and useful information out of the discussion. So, thank you.
You're welcome, Max. Thank you.
Okay, what did you think of that episode? I was very grateful for Professor Wimalawansa for explaining some of the core biochemistry underlying vitamin D physiology and how it affects immune system function. As I mentioned in the interview, I really believe humans should be getting and striving to get uh, all their or almost all their vitamin D from UVB light and not rely on either supplementation or food for vitamin D sufficiency. And as I've talked about extensively in previous interviews and videos, this is because sunlight has so many other collateral benefits especially in other wavelengths that we can't really ignore or just hyper focus on supplements to kind of get our level up. I think the position on the in hospital treatment of acutely ill patients, and particularly those with acute respiratory illnesses and viral illnesses, is really timely and relevant, using calcifediol as it was discussed, and really measuring vitamin D status on admission and then correcting it could be a very cheap and effective way of reducing in hospital mortality. So that is something that I'd encourage any physicians or internal medical intensive care physicians who might be listening to consider. Thanks for your support and stay tuned over the next couple months as I recommence the regular podcast cadence. So thank you for your support.